too. He has been with us since the beginning of our program. So going on 3 years now, we've had him. He has maintained sobriety with just a couple little hiccups at the very beginning, but other than that, he's maintained sobriety. He's experiencing withdrawal symptoms and like cravings and urges. Some of his specific symptoms are including sweaty hands, trouble sleeping. He wakes up drenched in sweat, restless and achy limbs. Let me see here. He has been complaining about these type of symptoms for, I want to say it's been at least like 6 months. He's been complaining of these type of symptoms. So it's not something that's just new, that's just came up. We did have him to get a thorough, medical workup to try to rule out any type of medical issues. He started out with our program weighing about 255, and then his current weight is 315, and he's 6'1", so he's not a little guy. Also, with his other medical symptoms that we've looked at, we had him we've tried to get him in to have a sleep study done. That isn't complete yet. Like, they haven't completely finished that process. There's been issues with his insurance, but he is at night sleeping with an oxygen machine. We did get the diagnosis of diabetes, which is treated. It's pretty well controlled at this point. He does have the gastrointestinal reflux disease, which we're treating that, and then the B12 and D vitamin deficiencies that are also being treated. He has been on the 8/2 milligrams sublingual films, 2 of those a day, since May of 2020. We have been looking at trying to get an increase of 4 milligrams for him, which has been denied. I think it was a couple of weeks ago, I brought him up real quick and got some ideas for different wording to try and get that increase completed for him. So what I'm looking for is just any ideas or suggestions, if there's anything else we should have done to try and address the type of symptoms he's having. If anybody has any ideas medically, is there something else we should be looking at with him? He has not had a lapse. I'm very impressed that he hasn't had a lapse. He's been real open with us on, his thoughts of wanting to use, but he has not used. This gentleman is still on probation, so I think that's part of what has kept him from having a lapse. So does anybody have any ideas or suggestions on what we could do differently with him?
Thank you so much, Laura, first and foremost, for presenting that case today. We really appreciate it and appreciate you. Before we jump into the recommendations from the hub members, does anyone on the call have any clarifying questions? And this is open to anyone, so feel free to unmute, chat in.
What medication does he take for his diabetes?
Sorry. Yay. I love these smartphones.
Oh, doesn't that always work? And it's at the
There's
never
so many
right
options.
timing.
Like, what?
Yeah.
Okay, let me pull him up real quick here and I can tell you. What am I looking at? His medication for?
What was that question again?
Diabetes.
Okay. I think they just got him on Ozempic, but let me pull him up real quick and give you the most
That was
up-to-date.
the question I was going to say. My husband is actually around that same weight, and they put him on the Ozempic, and he has done wonderful with it. He's also vitamin D, all that deficient, but that
Oh,
was going to be
wow.
my next suggestion. He's done really well with it. It's helped him, and that was going to be my next.
Let's see. He started the Ozempic. The Ozempic was started in August. And it's the 0.25 or 2 mg/1.5 ml pen injector.
Thank you. Any other questions from anyone for Laura and the case? All right, and any recommendations for Laura? I'm happy to pull up the case as well if you need to refer back to anything. I'll open it up to the group for any recommendations.
I was just gonna say that sweats or diaphoresis can be a side effect of Suboxone. So rather than a withdrawal symptom, it can be a side effect. And sometimes clonidine can help with that side effect. So you might want to try that. I'm not sure why he has restless legs, if that's related to Suboxone, or it seems odd to have withdrawal on something you've been on a stable dose for 6 months or whatever. It seems unlikely that's a withdrawal symptom.
Okay.
Sorry, don't have video right now. Any of his other medicines changed? You said he has bipolar disorder, some other mental health things. Anything changed? Any new meds that he's taking in this time period?
Let me look here. It doesn't look like anything's really changed. He's continued. He's also on somebody's going to have to help me. I can't remember the pantoprazole. I can't remember. Is that Prozac or is that a stomach pill?
It's
Protonics, it's
Protonic.
PPI.
Okay. Meloxicam, Flonase, the vitamin D3, the B12, Colase, and that's it. Zyrtec. I think this Vibrid might be an old one. No, this Vibrid's also, but it's also been started since August. So it looks like there's not been actually any changes in his meds at all since August.
And Laura, we got a couple chats in asking if he's anemic or maybe trauma history, could be having nightmares. And then another question asking how consistent he is with taking the medication. So I know I threw a lot out there right now, but.
I don't know for sure. I swear. My phone hasn't rang all day. I'm not sure about his trauma history, but I do know that he is very consistent with his individual therapy. He actually does more than what is required. I don't know about the anemic either. I can bring that up to his provider, possibly. And then what was the other one?
There was one about trauma history and then consistency with medication.
Okay. Yeah. As far as I know, he's really consistent with taking his meds. He's never talked about, missing any. His refills they're showing up in our system like he refills when he's supposed to.
And Billy had a good comment in the chat there saying RLS, likely complication of sleep apnea, weight loss would significantly help SA and RLS, magnesium levels, and possibly supplements. Thank you, Billy. And if you have anything else further to expand, you're welcome to unmute as well.
On that different person, on that magnesium side, the PPI, the pantoprazole can affect that level, usually negatively.
Okay.
So it's, you know, I mean, it might be truly needed, but a reassessment might be in place. If they were like 70, I'd say, yeah, get them off that, but they're not. So
Okay.
Has he tried just a simple PRN dose that like not adding to his normal scheduled dose to see if his symptoms go away?
Of Suboxone, he has not.
Okay. And is he experiencing the symptoms all throughout the day, evening time? Because maybe it's related to how his dosing schedule is. Does he have a history of chronic pain? I'm sorry, I didn't get to see all of your patient data when I was logging in.
Yeah, he does not have a history of chronic pain that I'm aware of. And I do know that we have explored different dosing options with him of, you know, taking it at different times, splitting the doses, taking them throughout the day. I know we've played with that.
Any other questions or comments from the group or recommendations?
I did get good feedback too from, you know, a couple of folks when I discussed this real briefly a couple of weeks ago of resubmitting to try and get that increase approved for him.
That's right. I'm happy that was helpful.
Yeah.
They responded to it at all yet? The medical director for National Drug?
They haven't, but honestly, I didn't get it submitted until Friday, and I haven't got to look at it today.
I would say if there's nothing medical that you can spot, then at least trying that higher dose. Are you going to try for 20 or 24?
We were just going to ask for 20.
Okay. Yeah, let us know. I mean, it'd be curious to see if just that little bit extra does the trick.
If it doesn't, yeah.
Yeah, it wouldn't be the first time.
I have another one that's similar, and I mean, I can wait and do this on a separate case if you guys would prefer, but I have another male patient. He's probably about 40 that's having increased symptoms as well. However, he was he holds a medical marijuana card and he has discontinued that use. And since he's discontinued the use of the medical marijuana, he's having a lot of increased symptoms, including the urges to use, cravings, anxiety, sweat, sleep disruption. I'm trying to get an increase for him too.
That's so interesting. We had a similar patient, but they didn't have medical marijuana. They just used regular marijuana. And when she quit, she started having a lot more cravings for opioids. So we moved her up from 12 to 16. And then she was able to come off of marijuana completely and no relapse. So I'm glad you brought that up, Laura. Thanks.
Yeah. And he has I don't have my group sheet in front of me, but he is roughly 60 days. He has tested negative for THC. And since he started, you know, testing negative, he's had the increase of the other symptoms.
And we got a chat asking, have you educated him on how to take the Suboxone correctly? How long does his dose last?
Yes, I'm not sure which person we're talking about there on that one, but like that's one of the first things we do is anytime a person starts having different symptoms, we look at taking that medication differently. And it seems to me that sometimes if they used more frequently when they were in active addiction, if they used more frequently, if they take the smaller doses more frequently, it seems to help. I don't know if it's a physical or psychological, but yeah, we always do try to look at that. And I preach to them to not use tobacco products 30 minutes before or after.
Any other questions or comments from the group about either patient? And Laura, did you have any other questions about your case, the first one or the second one?
I don't, but can I throw one more question out?
Absolutely.
So I'm going to have a meeting with my prescribers on Thursday, because we have 4 in our agency that can prescribe. And I just wanted to get a little feedback to make sure that I'm understanding the stance of like the approach from WVU and how we medically treat MAT patients. It's my understanding that when a patient is in group, that if they have any other like smaller medical concerns, that we can also treat those while we're seeing them. And like what I'm talking about is an abscessed tooth or a skin rash or a UTI. Is that pretty standard? Like this, is everybody else treating those type of symptoms when they're able to see their MAT patients for med management?
Marianne, I'm here at Healthy Minds Clarksburg. No, I do not. If they have other medical issues, I tell them that they need to be seen at urgent care to get taken care of. It becomes a little overwhelming if you've got 12 patients that you're trying to see in 30 minutes and they all have some medical complaints. So plus I encourage them anyway that they really need to get established with a primary care physician. So that's the way I've been handling it.
Okay.
Laura, we don't have a stance at WVU Medicine. It's really kind of up to provider and what the staffing is like in the moment. In terms of all of our hubs and spokes, I know they all do it differently. Some of them do have it sort of set up in their structure to provide more time to be able to meet other medical needs during those sessions, and sometimes the providers don't. In terms of our prescriber group, some of them are a little bit more lenient in terms of other, prescribing for other things. And some of them have that kind of hard line, just like what Dr. Long was saying of like, no, you really need to see somebody else. So we don't have sort of an official stance on that.
Okay. What we've been doing is if like the 30-minute med management meeting is med management meeting, like we're not doing anything else. And the same way as like Dr. Long said, if we have 12 people, we don't have time to talk about those other things. But if there is something going on that's small that can be treated, not like, chronic blood, like a chronic condition, please go see your PCP for a chronic condition. But like we'll let them step out of therapy group for 5 or 10 minutes to be seen for that issue.
Yeah, listen, I think if you have the staffing and you have the structured setup to make that happen, you could argue it's probably great for the right. It's a one-stop shop and they're getting their needs met there. So if that works for you all, yeah, I think that's great. A lot of our prescribers, what they'll do is if a patient is maybe running out of a medication, or they've, let's say they're running out of their antidepressant, or they have run out of it and they've got to set up, they have an appointment scheduled, but it's not for a couple of weeks away. Our prescribers will say, well, let's get you a bridge script because it's really important you stay on that medication. But listen, you got to, make sure you get to that appointment because we can't continually keep treating you for this.
Right. Okay. that's kind of like how I look at it. And because especially with where we're at, we're so rural that
Yeah.
a lot of times when we get these guys in here and ladies in here for med group, we ain't gonna get them back.
Yeah. Yeah. Yeah.
I just worry, like, if it's something, you know, something little that can be treated.
Sure. Yeah, it makes sense to capture them. Capture doesn't feel like the right word. If they're there for you to be able to see them in that moment, that makes a lot of sense.
I do a lot of that. I'm a family doc. I can't help myself. So I'm all the time treating blood pressure and talking about diabetes and all the other stuff too. So I often do those things.
Okay.
Yeah, and our
Just
group
wanted
is
to jump
split.
back to that
Oh,
first case. What's the non-farm side of life looking like? Because if asking for those authorizations, those might be some questions. I'm sure you could readily answer off track, but how's the therapy side going? How's the rest of that going?
On the first case, the one I turned in,
Yep.
this gentleman is the picture of compliance. Like he does more therapy than what he has to do. He actually does more groups than what he has to do. He comes in for group therapy. Well, he actually does it virtually when he doesn't have to be here. He'll still do virtual group therapy, and he's active with our topics. He's he's really great at even getting other patients to participate as well. He is working. He works full time. I don't know outside of, once he gets home, does he have any type of exercise regimen, anything like that? I don't know. But things are pretty functional. I mean, he's killing it with the adulting right now.
Put that on the form. He's killing, like, seriously.
He's killing it with the adulting. Don't make him mess up.
I mean, that stuff's important. Not
It
just
is, and with both of the two I talked about, the one that also discontinued the THC use, like they're both the most functional I've ever seen them, and they're both very frustrated because they're asking for help, and they're like, "Well, what am I supposed to do? Just go use? So then I'll be in a crisis." And I get that frustration, but both of these people have handled lots of legal issues. They're both, one of them's still on probation, the other one's off probation. They've overcome so much, and I get the frustration of it's easy to just say, screw it, I'm going to go mess up so I can get treated.
Thank you for that. That's just.
And Dr. Bo, did you have a question or comment as well? I noticed you had unmuted a little earlier.
oh, no. It was just to follow up with what Dr. Arban was saying, like provider preference. If a psychiatrist is running the group, they don't feel comfortable. If a med psych is running, we do medical stuff. That's all.
Yeah,
All of my providers are also like PCPs. I have a PA and 3 NPs from my credentialing.
yeah, and I'm family medicine, but part of the issue too is that we're not set up. I work out of a psychiatry place, so we don't have like urine dipsticks to, if somebody has a UTI, okay. We don't have anything to test, so that's part of the issue with us too.
Gotcha. And see, I've got it set up, like we have everything we need right here. And I have it I freeze my provider's schedule. I freeze it like for 45 minutes prior to group starting, because I know how it is when you're trying to see patients every 15 minutes. You're not going to be able to be here in 15 minutes. Those run over. And then I also freeze them for the 45 minutes after group, after the med management part of the group.
Any other comments or questions from the group?
Laura, FYI, I'm going to get your office number in the future when you're giving a case presentation. I'm going to call
Go
just to
right ahead.
see you get mad at your phone.
I love that. We're all gonna start calling Laura. Alrighty, well, thank you so much again, Laura, for submitting that case. It always sparks such great conversation when.
Yeah, thanks for everybody's feedback, especially, there's some other things I'll get with the provider on the actual case I presented to maybe look at.
Absolutely.
We can get him feeling better.
Yeah, that sounds good. Thank you so much. And I second what Laura said. Thank you all so much for the feedback and comments and great discussion. So thank you all. You all are welcome to submit cases as well and reach out to Elizabeth and myself if you want some help submitting any cases. So thank you. Thank you. Dr. Garofoli, I'll turn things over to you for your presentation now. So let me know if you have any trouble screen sharing or tech is giving you trouble. I have it on my end as well. All right.
I am having the easiest Monday ever, so don't worry. Woke up and our kid puked 6 times and my wife's pregnant, so we skedaddled her next door to my in-laws. Yes, I live next door to my in-laws. And it's a Monday, so this is like only the second thing I had to do semi-professionally today. Anyways, let me pull up the screen here to share with all of you. And can you guys see just the title screen? All right, I see some thumbs up. Thank you. Thank you. All right. So let me see some faces here too. What I was asked to go over here was buprenorphine and pain management. I think in this particular group, whether you're brand new or you've been to 2 or 200 of these sessions, we've talked about buprenorphine before, that's for sure. Even 5 minutes ago. It's an amazing substance, that's for darn sure. Given the reality of the last month or so, I wanted to briefly cover the updated acts for the information that's out there, and then cover some stuff with buprenorphine, basically. One of my 3 or 4 pictures for explaining buprenorphine, it's got a lot going on. It takes different perspectives. Everyone here works in the SUD realm, so you know about perspectives, of course. So we got to keep that in mind going through things. Whenever I get down to the pharmacology, my tone, my words might sound like this is how it is, and feel free to tell me that this is not how it is, because we're dealing with humans. Kind of like the question I asked about 5 minutes ago of, hey, how's the rest of life going for the gentleman? And there was arms going up in our crowd for yes. Well done. Onward to the prior Ross. I know my language. It's a Monday. But anyways, so obviously the X waiver's gone. Multiple versions of that overall to get it done in the end. But, whatever Congress had to do to include things in a budget here or there, the X waiver's gone. The training is not necessarily gone. Quite a little power move, of course. Shifting it to everyone. So let me just go to the next screen here too. About 80% of this slide I actually put on LinkedIn a week ago, and there's literally been 20,000 hits on the thing. So I feel like if some random dude from West Virginia can do that, it turns out a lot of people in our society are paying attention to this. Although we're going to talk about the micrograms and the pain side of things here today, I just wanted to cover some of this stuff up front. Obviously, buprenorphine is a controlled substance 3 for the last couple decades. That 8 hours of SUD training will be starting this summer, and it's going to be for everyone with a DEA license. So it used to be those interested, now it's everyone, whenever renewing, which I believe is every 3 years. The limits on number of patients are gone. There still is that federal corresponding legal responsibility for prescribers and dispensers for the 2 lowest hanging fruit out there of proper diagnosis and scope of practice. I mentioned that just for people to not in that proverbial stay in your lane, but the keeping everything in mind there as well too. And not necessarily in our state, but different states have different rules here and there. I was just looking up something earlier for somebody else. I swear I was off today. And there's like 10 states that even have pharmacists having the ability to prescribe or even administer various things like people controlled substances. Something that gets lost in every headline, and I swear the media hates my profession, but hey, there's probably people in our profession that hate our profession too, so whatever. Some of the biggest barriers out there, of course, are at the pharmacy level. And that's coming from the urination contest back and forth with DEA wholesaler distributors. Typically anymore, it's on the wholesaler distributors for setting the limits for the amount of buprenorphine, typically milligram products that a pharmacy can get. And on the other side of the coin, I believe there was just headlines within the last couple of days of some more opioid settlements. And some of the core of that is for not having limits. Well, if we sue the pants off somebody for not having limits, and then they have limits, there's that story. Hopefully my tone says I'm not on any side, but there's a reality out there. There's two sides to every coin, and Bitcoin has many more even. And to think that the 8 hours of CE is what was actually stopping people from getting an X waiver is about the silliest thing you'd heard about 5 years ago, right? Okay. Yet we read it again and again and again, and I'm like, oh my gosh. Anyways, so that's that. Wait, any thoughts, questions anybody wanted to pull out for that? Because kind of before the whole pain thing we were going to go over here today, but yeah, and feel free to follow up afterwards, of course, too. So a couple of the things we'll go over in the pain management realm with buprenorphine on there. Big picture, typically micrograms pain management, milligrams opioid use disorder. But of course, a patient with opioid use disorder could also get hurt. Car accidents happen, broken legs happen, kidney stones happen. Too soon for me, that's for sure. Anyways, you gotta keep that in mind just for the FDA approvals. To think that off-label is something that is never ever done, my goodness. So we gotta keep that in mind. One thing that blows my mind away is, so we have our package inserts, the little -15 font, tiny little pieces of paper that every pharmacy tends to throw away because they just need to be on every little bottle for whatever reason. Not the things that are handed to a patient, but what's put on the bottles on the shelves. So the package inserts will have things in there like a black box warning. Like I can't even give that effect. In healthcare, we feel like, oh, if it has a black box, like, okay, we address that. Done with that. Okay. I don't get it. Perhaps I was trained by my dad, who had nothing to do with healthcare, to use common sense. Like, okay, it's typed words with a black box around it. What's so big? But when it comes to buprenorphine, the MAT products, which would have a relatively much higher dose than the microgram pain products, don't have the warning, whereas the microgram products do. Now, I'm sure anyone here could also figure out, and already know, probably already thinking of like, well, yeah, but if you're already utilizing the milligram products, well, you're probably already thinking down that road anyway. Yeah, but if you're going to subscribe to the idea of using these black box warnings, then perhaps put them on both. It's an interesting one. So down to those microgram, typically, products got 3 bigger picture options, really. I'll fill in this chart for you, don't worry. And they'll be sending the handout, already got it ready later on. But you got your buccal or buccal formulation, your transdermal, and then of course the solution for injection. Just wanted to cover a couple things here in each of those products or selections here along the way. I think you fully know I'm not a drug rep, but I am using a picture that came from the World Wide Web because sometimes the things are pretty straightforward. Okay, this is from one of the original studies here for the transdermal patch, Butrans. And here's the little pharmacologist in me shining and being very nitpicky for my patients. If you guys should be able to see my mouse, I think. So, using the patch, you're going to get up to this 200 level. It's around day 2-ish or so. And then if going down about a week later, all of a sudden you're hovering around like the day before that last day of the patch, you're at about $1.25. And that's okay, according to the studies. But in a patient-centered focus, I wonders about that. Because if we're used to getting up to 200 to get effect, and now it's all the way down to that 125 right before you poke back up, I promise you, this is not the clinical trials for OxyContin from 1995. Okay. But it is the same company. So there's that. But in 2023, we're America and we own that company. So just things to keep in mind as far as the patch goes, because the patch could be viewed as relatively easy. Stick it on, good to go, right? Just watch those later days with that, as per the trial that you're seeing there now. One of the other tricky parts with buprenorphine microgram products when it comes to pain is the actual initiation. It's like anything else in healthcare, we typically peak at about 7th grade math. If we get wild and wicked at 8th grade, it's a miracle. But no one does 7th and 8th grade math every day and utilizes it really quick. Can't wait till my kids at that level, or both of them at this point, because they'll be running circles around us. It takes a moment to stop. It's not like other prescription opioids. You gotta kind of stop and think through it. There's a lot of information in this slide. I would say it's a terrible slide. The whole point is when using any of these products, you could go to the actual websites and they'll walk you through the calculators for where to start somebody. So if looking at the chart that I adapted over here, these lower doses here are actually a limit because of how the product was studied. It doesn't mean chemically. It means that at the time of approval, they studied up to 80 MMEs per se. Daily of a comparison. They're saying, so if somebody's utilizing more than 80 MMEs, they're saying consider an alternative for the transdermal product. Well, that gets really tricky for a lot of patients in pain, eh? So that brings up that as far as how it was studied. Jumping over to the sublingual, I'm sorry, that should actually say the buccal there. My bad. Way cooler though is the one time I was giving a CE and I had the placebo, the fake versions of this thing. That was in my office today. I'd have them, but that's not the point. Is how cool the actual fake product was. This is one of the best versions of child proofing because I swear it could keep us adults out like no other. If you look at the bottom of this slide, it's very simple. The patient has to fold the top of that little foil pack over and then rip it open. Well, I was given a presentation one time, Wild and Wonderful, West Virginia, nice stage, and I screwed the thing up. And there was a gentleman in the crowd that had a Rambo knife, okay, a really big knife. And he's like, "Hey, kiddo, and he was older than me, right?" He's like, "Hey, kiddo, you need this thing?" And I'm like, I was at a decision point, and I'm like, okay, the me was like, "Oh, hell yeah," but how do I actually make this okay to do? And I was like, why not? I'll try and not hurt myself. And I used the thing and I opened it and I handed it directly back to him. Was like, "Get this out of my presence. I will hurt myself by accident." And we went on. Anyways, the whole point of that ruckus is to remind everybody that, like, if you're ever utilizing this, it's worth that extra 5 seconds to just show the patient how to open the thing. Because, it's like gabapentin, the poster child for start low, go slow. If you crank the dose too much in the beginning, you lose that option forever. And it could be a good option. So this, again, buccal, not sublingual, sorry, has the same intricacies for initiation. However, it's a little bit higher over here at 160 as the cutoff for what was studied. And here's just a picture of some of those online things for actually initiating that along the way. So here's some of the everything filled in basically for the quick go-to chart. In case anyone's ever running into that realm of adding microgram. It's a little bit less frequent, obviously, with milligram adding microgram, not quite as sensible, I guess, but if starting in that realm overall. All right, couple other things, because then we'll navigate into the whole, what about milligrams for pain, even though that's not an FDA approval, but it's same chemical substance, same medication. One thing to keep in mind, of course, is the magnetism of buprenorphine to the mu opioid receptor. That's all this chart, or these charts, I should say, is portraying here. The one on the left is really where it's at. Sufentanil, we have very, very low utilization of that product or products in our healthcare system in our country. So really at the almost top is buprenorphine for the highest magnetism. Those fancy Ks, it's the lower the K number, the higher the magnetism, the affinity to the receptor. Where does that come into play, and why do I care about that? And other than wanting to just inject everyone with pharmacology. So it's when it's up against other opioids, it's not necessarily a head-to-head battle, but there's so many receptors, there's a lot of them. Buprenorphine is going to win just about every time. So think about that with a product like buprenorphine naloxone. We were talking about that in the case earlier. Naloxone's put in there for deterring abuse. However, is that pharmacologically sound? No. And it's because of the information on this slide. So there's that. We'll come back to some of that, I think. Let me check the chat here. Okay, I think I'm doing good. Okay, on volume now. But so metabolism with buprenorphine, the main thing is, as far as CYP450, the infamous liver hepatic metabolism is 3A4. If you ever have to guess what CYP450 enzyme metabolizes a medicine, you guess 3A4 because it's the most common one. Grapefruit juice comes into play with 3A4. But do we ever have any concerns or issues with things like grapefruit juice or any metabolic interactions, things like that with buprenorphine? Typically not a lot. It happens, but typically not a lot. And that's because of lower on this slide here, kind of in the middle, actually, the metabolites end up being active in certain ways as well, particularly for the mu all the way on the left there. So it's one of those where, well, the medicine itself and its metabolites are both active. So are we really intensely worried about the metabolism? Well, really only when it comes to if you're looking at the specific effects, analgesia compared to respiratory depression, a little bit different there. So that could come into play, but it's not as big as with other medications along the way too. MME factors or morphine milligram equivalent factors. So the CDC just dropped their opioid guideline update in November. Those on video, people aware of that? Knowing of that? Okay. It's better if going like this, because it's I've got some resources at the end here, just a slide or two that'll help with that. So the CDC updated their opioid guidelines and expanded some things and did absolutely nothing on some other things. Created a little bit more of a ruckus on a few things. Is my new favorite thing to tell our students, particularly our student pharmacists, to journal club and look up references, because I ate them alive when it came to acute pain. One of their realms was nephrolithiasis, kidney stones. And I'm like, oh, let me look at that one. And pitiful. Anyways, I had the main PharmD author on my podcast and everything. We had a great conversation. But anyways, when those original opioid guidelines were released, the MME factor for to relatively attempt to compare opioids potency per se, the factor was 10. In less than a year, it magically became 30 because a number of us reached out to the CDC and said, yeah, your references are a little bit of a malarkey there. The reason these pictures are on this slide is because I was in the Cosmo in Vegas utilizing a first edition iPhone SE and was able to figure out and find references that were better than what they had published. And I find that remarkable. I wasn't alone, there was other people too. So that got changed. And then it became unlisted because of a concern for stigma. There's a reality there. If it's 30 times 16 milligrams in a buprenorphine dose, you're up to 480. That's well above published concerns, we'll say. That new opioid guideline update that was just published 2 months ago, things are still unlisted. It doesn't mean that 30 was incorrect. It means that there was a concern for the stigma side of things, even though it was already published before, which is not necessarily the best way to address stigma. Publish and then pull away. Good golly. All right, we had this come up in the case earlier today, just some possible, perhaps even common side effects with buprenorphine. So that whole sweating, we use fancier words in healthcare, but sweating, can't sleep, peripheral edema is one that comes up observationally. I don't know if anybody else, along the way too. There was some hoopla probably a year ago now. I can't see the date on that thing I have on there, but top left, about the dental problems with the sublingual buccal formulations. I mean, the most straight to the point way of helping our patients with that is just saying to swish and swallow with water after utilization of those products. The reasoning for that is it's just the pH of it's not necessarily buprenorphine, it's buprenorphine in those particular products. The pH, that wonderful stuff that, all the scouts make potato batteries with. The pH of those products is a little bit less than something like wine. So, wine's fine typically with a glass, but if it had a little bit more acidity to it, we might start worrying about our teeth and maybe limit. The swish and swallow afterwards can help with that. I always hesitate with healthcare professionals to mention serotonin syndrome because it's one of those where you have 100 people in a room, one saw it twice and 99 never. It's there, it's a possibility, it's a serotonergic opioid. All right, here's as far as the products that everyone here, I'm sure well aware of, just a general comparison here of relative doses as far as what's available for the milligram products. If people would like more information in the pain realm, here's a narrative review I did two or 3 years ago, 2 years ago, see it now. If anybody wanted to look that one up, I guess, just for a little bit more intent thing. I like to make things a little bit more conversational here though. Across the globe, there's another product that's not available in our country. It's just the sublingual tablets for pain. So we have the buccal and the transdermal solution for injection. Not the rest of the world, but a vast majority of the rest of the world also has sublingual tablets as well in those microgram doses. So I'm also going to have an all things buprenorphine episode of a podcast at the end of this month. So feel free to check that out if you'd like. You could use any of those fancy Apple or Android or whatever else podcast things. I host a podcast. I don't listen to a lot of podcasts, but anyways, and the typical quote for buprenorphine with some beautiful national park in the background is, "I'm the most misunderstood, misquoted medication I know, honestly." Buprenorphine. Oh, yes. There's a lot of complicated things out there. If we could figure out why in the world pizza is often round, placed in a square box, and then cut into triangles to be eaten, maybe we'd stand a chance to truly, truly understand buprenorphine for all that it's worth. Being the pharmacist that I am, I wanted to point out that the E in pharmacy stands for easy. And there's an E in buprenorphine, so we can't say the same thing. But I think, leave everyone with that part. We're actually good on time for once. Questions, thoughts, discussion, even beyond me for anyone?
Thank you so much, Dr. Groffley. Awesome presentation as always, and we always love your humor throughout your presentation, so we appreciate you. But yeah, open it up to any questions or comments from the group. Dr. Hirschler, I see you've unmuted.
Yeah, I have a question. So Mark, it seems to me in my work with pain and buprenorphine is that the peak and trough effects seem to affect analgesia. And do you know anything about Sublocade for pain?
So I haven't actually seen that observed anyway for utilization, like on the chronic side. The thinking with it though, so again, that's going to be comparative more to that milligram side. But again, I didn't dive too deep into it, but that idea of, milligram products, particularly the twos, being utilized for pain, it happens out there. It's interesting when you talk to people in general, whether it's pharmacists, doctors, nurses, PAs, whoever, some are like, you can't do that. It's never been done before. And others are like, we do it all day. What's wrong? It just takes some people longer, I guess. Sometimes my father-in-law says that, but anyways, the Sublocade idea, that's, more so on that keeping up with milligram side of life as well. But if somebody were going to be contemplating the use of, say, a buprenorphine low milligram product, if there was tolerance with opioids, along prescription opioids along the way, and then converting over. It's very intricate scenarios. but it wouldn't be, you know, in a textbook sense, you would think, well, you know, why not? You want to take a step further or two there to you know, to assess, well, you know, would there need to be also an add-on? How do you deal with, is it enough? Is it too much? Not necessarily in the respiratory depression sense, but is it more than what you need to take care of the pain side of things? Because it does come with its potency, of course, in the pain sense especially, but not seeing that yet, but maybe if having this talk in a year or two, maybe we'll see more. What were you, Dr. Herschel, what were you thinking there? Like maybe, hey, maybe we should, or?
Well, part of the work I do is working with people who have opiate use disorder and chronic pain. And so I'm using buprenorphine and Suboxone form or Zubsolv form to treat chronic pain in somebody who also has addiction. And so we're using doses that are addiction related doses, but also working to get analgesia from them. And it's my experience that dosing it, you know, every 4 to 6 hours rather than, you know, once a day gives you better analgesia for some reason.
It's I hesitate to say this because it depending on where people's minds are, it opens up a can of worms. But I'm here to help and talk. Kind of like we think about with methadone, you know, once a day would be on the OUD sense, but maybe 3-4 times a day, probably 4 would be on the pain management sense, because the dose response curves, here I go, pharmacy, yay. The frequency is needed more for pain. Buprenorphine
Is that
not
peak
the
and
same as
trough, or what is that, Mark? Is the
What's
peak of the medicine when they absorb it? Is that what's giving them the analgesia then, or?
It's how would I best explain this one? So like one of the things that we always say when it comes, again, this would be with methadone, you know, when you're looking for the response, the occupying receptors, it's perfectly fine, expected for once a day dosing, but to get pain management, it's a different response. So it's a different concern for occupying the receptors and getting different effects. So it's needed to have multiple times a day. It would be I don't like saying red flags. It'd be some kind of flag if somebody was utilizing, say, methadone not once a day or not multiple times a day for pain. Buprenorphine is somewhat similar, but not the same by any means. The products are automatically more the transdermal, that answers itself, of course, with the week, but as far as the buccal formulations, it's more. And that's almost expected because you just typically need that more frequent touch for pain. Yet, ironically enough, in not all cases, but the cases that make settings like this,